That the therapy is something else. That's mostly chemotherapy and sometimes bone marrow replacement. Sometimes they have bone marrow replacement, and then, but before they do bone marrow replacement, whatever malignant cells are circulating, they have to be killed. So that's why they give chemotherapy, that's give the radiation therapy. And the radiation therapy is what? Whole body. That's called total body radiation. So the whole purpose of radiation therapy is to kill the malignant cells and spare the normal tissue. When the people get total body radiation, they get very sick, because you are not only giving to the dose to the cancer cells, you are also giving the dose to the other normal organs also. And blood has also other nutrients and other kind of things which helps the people to live. And then you irradiate the whole body, then they get sick. But of course, with time, those total body irradiation, they have decided what dose is needed so that people don't get very sick and die out of it. Okay, so these things have been decided by what? By clinical trials, that which works best, and that still is going on, because the physicians, by through different, what happens in medical science? Medical science is not an exact science; it's an empirical science. You come up with a hypothesis from preclinical experiments, laboratory experiment, bench to bed. That's called bench to bed. In the bench, there is some experiment. From there, they find something new, biological or biomedical process. They think that this will give a better outcome of the current practice therapy. So then that's called the laboratory bench. Then there is a hypothesis. Then you do a clinical trial. In the clinical trial, you first decide whether the thing that you are proposing, new thing you are proposing, is safe or not. That's called phase 1 trial. Then after that, it goes to different efficacy, then eventually goes to phase 3 trial, which is the final trial. So this process is pretty long and very expensive, okay? So in medical science, specifically radiation oncology, if you are going to get a new therapeutic thing, then you have to make sure the therapy that you are proposing is better than what you are practicing. If it is not better, then that gets rejected. Many things go down the drain because they don't work very well. Okay, so that's what happens. So in radiation oncology, that's what happens. You have something going on, because the patients cannot wait till you decide what is going to work. The patients have to be treated. So that's why they tell the outcome will be some probability that you will be cured, some probability that you will not be able to cure it. So that's how it works. Medical science is not exact science. So if you want to remember one sentence from what I have discussed so far, the medical science is not exact science, it's an empirical science. Don't tell the medical doctors, they will be unhappy with it. They think they are doing exact science. But as a physicist, biologist, or a determinist scientist, we normally think that's a very empirical science, okay? Professor Giri does the experiment, and they wanted to determine exactly after quantum electrodynamics is good up to 10 to the power minus 14 places or something like that. I don't remember, because I have forgotten it, okay? So you seem to be too serious. Don't be too serious, okay? These are very simple things, these are simple things. I'm talking simple things, okay? So the objective of radiation therapy is optimum complication-free tumor control, and the whole thing can be described here. So you give some dose, you have some probability of killing the tumor. That's called what? Tumor control probability. Okay, and when this dose is given to normal tissue, they will have some complications. That's called normal tissue complication probability. Radiation interaction with cells or any tissue is a stochastic process. So that is a statistic. So you cannot for sure tell that this is going to happen. It's a probability. So that's why that this so you understand very well. So what is the therapeutic efficacy? You take the tumor control probability divided by normal tissue complication probability, then that will give you the therapeutic efficacy. How good is your therapy? Okay, and how will you optimize it? You want to have as large as a TCP and as low as a NTCP. Okay, so that is the whole scope of radiation oncology in one sentence. We wanted to have maximum TCP, NTCP, and you can see give as much dose as possible, then your TCP will be higher. Give as low doses to the normal tissue, then your NTCP will be lower. There is a principle in radiation safety. Okay, if those of you who have studied it in radiation safety, if you want to save yourself from too much of exposure, what you do is you maintain a distance. If the normal tissue is far away from the what you are irradiating, then you give less. And that luxury sometimes is not available. Sometimes all the critical organs, for some reason, the tumor grows close to the normal organ. So that is the challenge for the physicist. But if you are lucky, sometimes we get something is far away from thing that is our the best target to treat for radiation physics point of view. Okay, okay, distance. Then there is called time. Minimize the time. Don't stay too long near the radiation source. Get out as soon as possible. Be very proficient. Get your work done as soon as possible and run away. Then you reduce your exposure. Shielding. Put a shielding around you. If there is something, then you can shield. That's what we do very well. In radiation physics or in radiation therapy, we wanted to block those critical organs as much as possible, so they will get as low as dose as possible. Then dose, of course, you try don't get exposed to too much of a dose, reduce as much as possible. Okay, so that is also applicable to also in treatment planning. When you are doing radiation oncology, that's what the principle is. Okay, so nowadays you all know about, because everybody is aware of CT scanners. Everybody is aware of magnetic resonance scanners, imagers. You are aware of PET scanners. All those things provide different information to the physician to define what they want to treat. That's called delineation of the target. As a physicist or as a planner of how to give the radiation, we need to know, localize in an image where the target is, where the critical organs are and those kinds of are necessary before we do a treatment plan. Nowadays, because the computerized treatment plans are very much possible, so we normally create a customized plan for every patient. Okay, although there are some class solutions like treating a prostate. Prostate location is very much standardized. It doesn't vary from person to person that much, and the critical organs doesn't change from person to person. You have bladder, you have rectum, you have urethra, and you have the femoral heads, all kinds of things. That's pretty standard. So the beam from which direction the beam will go is pretty much known. Only thing you decide the target volume, what the target volume and how far the rectum is. And as I mentioned to you that you can always put some shielding to protect your critical organ. So between prostate and the rectum, you can always put a spacer. That surgically you can put a spacer, that's called a gel. So that pushes the rectum away. So you can reduce the dose to the rectum. Because if you give too much of dose to the rectum, then people will have reactions, bowel movement, loose bowel movement, and bladder irritation, all kinds of things. So that's possible. So what I'm talking is the image-based customized treatment planning for conformal radiation therapy. What is conformal radiation therapy? Go back to the principle of radiation oncology, to give as much dose to the target and as low dose as the target. So you wanted to create a dose distribution which is conforming very much to the target, nothing spilling out. Imagine you have suppose you are given a paintbrush. You are asked only to paint this much region. Don't spill any paint outside. If you can do that, then you are the greatest painter, okay, for radiation oncology. But paint brushes are not that a single point. Paint brushes has a certain extension. And when you are putting your brush in that target, some paint do spill out. So that's why normal tissue gets some dose. So it's never possible to exactly irradiate the target. But if you can create a sharp gradient for some direction, then dose to the normal tissue will be reduced. So in case of brain targets, very small targets, what they do? They want to create a beam dose gradient so much that normal tissue damage is reduced as much as possible. So they use something called a cone, 5 millimeter cone, 1 millimeter cone, or something like that. So that way, and it is very close to the body, so that the penumbra of the dose follow-up is very sharp. Okay, so that's how it is. So what I'm talking is that image-based customized treatment planning for conformal radiation therapy is very much possible nowadays. Okay, the technology has developed so much that we can do precise dose delivery as per the physician wants. That's possible. And that is possible because of the availability of imaging modality, the availability of large storage space. Because if you take an image of a person's body, it eats up a lot of space. But nowadays, hardware is very cheap. Okay, and the softwares have also become very sophisticated. We can develop, and there are vendors, there are companies who make a lot of money out of it. So they have a developmental team which try to make the treatment planning system as good as possible, as accurate as possible. The dose calculation, in order to do a treatment plan, you have to have a dose calculation engine which is going to model the beam that you are going to use and then calculate the dose from that beam. And those calculations have also become very sophisticated, very accurate and very precise. So precise dose calculation and precise dose delivery is very much possible. Okay? So that is something that you should know, that is something called inverse planning. And that let me go back to that slide where if I can come to the inverse planning. Okay. So I'll come to inverse planning later, because you have to know inverse planning, because without that you will not get idea what are the modern treatment plans, how the modern treatment plans are done. Okay, so in order to irradiate the patient, you have to have a different radiation source. We have X-rays. The X-rays can be kV X-rays, can be very MV X-rays. Okay, megavolt X-rays, that's 6 MV, 8 MV. Because the X-rays do not penetrate too far. The penetration depth of the X-rays depend upon its energy. So as soon as the X-rays were discovered, people started using it to kill to use as radiation therapy, because they found that this radiation can damage kill the cells, specifically the tumor cells. So at that time there are just very low energy kV images, say kV X-rays. Those X-rays can penetrate 3 to 4 millimeter or 5 millimeter maximum. So naturally you cannot really treat deep-seated tumors. So if you try to use them for treating deep-seated tumors, you will irradiate the skin to too much of a dose, and then there will be skin reactions, and people have different. So then different developments happen in the radiation source development. We can have a linear accelerator in a 200-meter machine, and that linear accelerator can accelerate the electron to 200 MeV energy, and then you heat it to the target in the machine head. Then it will create a Bremsstrahlung X-rays, which can be up to 6 MV, 18 MV, up to 25 MV. But another important development took place in radiation oncology. That cobalt-60 was discovered, and cobalt-60 has a very long life, 5-6 years. And this can be put into kind of pallet, and this can be sealed, can be kept in a shielded head, and that can be put in a machine, and that can rotate around. So with cobalt-60 in the beginning, before the accelerators came, with cobalt-60, which can penetrate it very deep into it's 1.25 MeV gamma rays. So you can penetrate at least deeper into the body, and if you are rotating, you are reducing the dose to the skin from one direction. So you can still irradiate the target with a reasonable amount of dose without giving too much of dose to the skin. Okay, so that's what cobalt-60 happened. But then cobalt-60 is a radioactive source; it has to be changed, and the source decays, and then gradually the treatment times becomes longer. But with linear accelerator, I'll show you a linear accelerator machine. With linear accelerator, that there's no radioactive source; it is power. If you turn off the power, the beam is off. Okay, so the development of a linear accelerator revolutionized the field of radiation therapy. Within $1 million, you can buy a very high energy LINAC, and those are the workhorses everywhere now. In the beginning in India, cobalt-60 used to be used. There are still many places people use cobalt-60 because they are cheap. But linear accelerators are not made here, it is imported from outside. So they are expensive, but nowadays money is not a concern in India anymore. So a lot of private hospitals, they have a lot of very state-of-the-art linear accelerators also. Okay? Any questions so far, so far? You are getting some idea what is going on in radiation, or is just a refresher that those people who already know about it? Okay. So So then of course you have protons, neutrons, all kinds of heavy charged particles. They are experimented when they are discovered. And there are in Los, there's a laboratory called Los Alamos National Laboratory in USA, in New Mexico. They had these sources like neutron, pi mesons, heavy charged particles in Berkeley, where the cyclotron was discovered. They did a lot of experiment, radiobiological experiment. Actually, what is his name? The person who discovered cyclotron. I'm not able to remember his name. He treated his mother with that radiation, with the protons and heavy charged particles. Okay, the cyclotron. When you come to me, I'll tell you. Okay, it's not coming to me right now. So all those things were experimented, and how the radiation. What happens when the radiation interacts with the tissue molecules inside the body? There is a indirect and a direct ionization process. In the indirect process, it goes and interacts with the electrons, and those electrons they get ionized, and they get separated from the atom. They go and damage the single strand of the DNA or double strand of the DNA. But there is a direct ionization process. Like sometimes that even that electron can hit and go directly hit two bonds. That's called a direct ionization. The two bonds are broken means that is very lethal. The cell cannot anymore replicate, cannot anymore divide. It's lethal. It's lethal. Getting two strand breaks is the aim. But if you have a very sparsely ionizing radiation like photons or electrons, they normally break only single strand bonds, and if they're nearby, then they interact, and then the cell can die. But heavy charged particles, they go and directly hit the double strands. So that's why they are much more lethal. But there are a lot of uncertainties. They are also lethal to the normal tissue also. So that's why they have a theoretical advantage, but there are so much of uncertainties, as we will discuss in proton therapy, that you have to be very careful how to use it. You have to know how to use it, how to take care of all those uncertainties, and you have to design plans. Even if with those uncertainties, you have created a plan that still some benefit, the patient will benefit from your plan. Okay, so that is the task of the physicist, to make sure that despite all these uncertainties in heavy charged particles like protons and heavy charged particles, still you can get some benefit compared to safer treatment modalities. Okay, why do people take risk? No risk, no gain. You have to take some risk, get some gain, but of course we are dealing with the patients. Okay, you have to make sure that the risk that you are taking is worth taking the risk. That the clinical gain is much higher than the risk you are taking. Of course, that's always life's that strategy. Okay, you take a risk, take a calculated risk, knowledge-based risk, so that eventually you gain something. Okay, that's what happens. That is applicable to anything, everything. Let me see. Okay. Important thing is, you are radiating both the normal tissue, you are radiating the tissue also. Okay. Then you are giving the same almost close dose to each other. Then why the normal tissue will not die? Because normal tissue has some, the microenvironment of a normal tissue is such that they have the ability to repair up to certain level. Okay. And for the same dose, the tumor cells cannot repair that much. So what happens when you give the dose and give a break, the normal tissue recover during that time, whereas the tumor cells are not able to recover. So they're dying. So the death of the tumor cells with time is accumulating, whereas the normal tissue, the death is happening, but they recover. You cannot give a radiation dose without allowing the normal tissue to recover. And that's why there is something called a normal tissue tolerance, that every normal tissue has a tolerance dose. So when you give that dose, when you irradiate the patient when patient receives radiation therapy, the aim is to give the dose to the organs at risk within that tolerance. Okay, that is the planning objective of the planning. That's I told you in the beginning, the normal tissue complication probability to a lowest level. Okay, and also that the tumor cells, not all the cells will die similarly or with the same amount of cell. Malignant cells will die with the same amount of dose. It depends upon their environment, depends on the genetic structure, all kinds of things, very complicated. And how much cells will die with certain amount of dose is determined by the radiation sensitivity of that particular malignant cells, that structure. Okay, so based on that, those are determined in the laboratory by radiobiological experiments, from clinical outcome, all kinds of things. So based on that, as I mentioned to you, using clinical trials, the dose prescription and how many days you want to treat with how much dose is decided for the standard practice. You of course come up with new ideas, try to do new clinical trial and prove that by a different dose and different dose fractionation scheme. Dose fractionation scheme means how much dose you give every day and how many days. Okay, those things are developing now. Something that's called a stereotactic body radiation therapy. In this case, because we have so much of ability of reducing the dose to the normal tissue, we can give a very large amount of dose to the tumor, but keeping the normal tissue tolerance, the normal tissue dose under that tolerance. It's possible now because of our ability of localizing the target during the treatment. Before, those imaging ability was not there. Now, in the treatment head, the machine that you are using to irradiate the patient has some imaging capability. They can take a 3D image of the body while you are irradiating, before you irradiate. So that way you can know that, okay, am I localizing the target what I am irradiating properly or not? Before that, the uncertainties in setup was about 5 millimeters. But now those uncertainties have been reduced to a millimeter level. Okay, so that imagine now the normal tissue, the exposure has been much reduced. So they can take a little bit higher dose, and so we can increase the dose to the target to a higher dose. Okay, so this is called a stereotactic body radiation therapy. I'll talk to you more about stereotactic body radiation therapy, specifically stereotactic body proton therapy in the last lecture. Okay, so I'm not going to jump into that. But what I'm saying is, the dose and fractionation and all kinds of things are evolving. Okay. Where we are. So there are three kinds of radiation oncology process. One is the external beam. A patient comes and you have an external machine which irradiates the patient without any kind of intervention or anything. Of course, you have to immobilize the patient properly so that the patient is not moving during the treatment. We have many tools now to localize the patient, not to monitor the patient's movement. You see, nowadays the cameras are very cheap, or the good camera, high resolution cameras are available. So you can put some cameras in the treatment room and monitor the patient's surface. You have a reference surface that you wanted the patient to be, and then when you are treating, you are also taking image of the surface and see that what variation is taking place. That's called surface guided radiation therapy. So that helps for the patient to monitor the patient movement. And you can also connect the SGRT machine to your delivery machine. If the patient movement is more than tolerance, the beam stops, so that you can irradiate there. Okay, so that helps to prevent irradiating wrong patient at a wrong location. Okay, so that's what helps to localize those very well. Okay. So this is the standard dose, 100 to 400 centigrade per minute, and normally external beam dose is given 180 to 200 centigrade per fractions. And there is of course the brachytherapy, that in low dose continuous radiation like say iodine seeds and iridium seeds, all kinds of things. They are put inside the body and they stay there, and they have low energy. So they do not damage much of the normal tissue, but they continuously give the dose to the target, and there is some biological advantage of that continuous dose radiation at low dose rate. Okay, so but in this case, when you are putting a seed inside the patient or putting a what is that called cesium seeds, large seeds inside the body's cavities, the patient has to stay in the hospital. But no, iodine seeds are so low, even if you put inside the patient, patients can leave the hospital. Okay, but high energy radioisotopes, if there is a radiation hazard, then they stay in the hospital. And sometimes it's interventional, because you cannot put the seeds without going surgical procedure. So that's why brachytherapy, although is the most conformal treatment therapy, is not very much practiced. Sometimes physicians are not skilled enough that they don't practice it. But those people who know how to do brachytherapy, they will always do the brachytherapy. Because in brachytherapy, what you are doing, brachytherapy means a therapy at a short distance. So you are putting the radiation source very close to the, either inside the target or very close to the target. So naturally the dose to the normal tissue is very much minimal. Okay, but it has its own uncertainties and all kinds of things. So something happened that we have development happened, that's in a machine. Let me go and bring that machine. See, I should not have, once I start, I can stop it now. Too much. Okay. Here, you see, this is a high dose rate afterloader. You might have seen it. In a high dose rate brachytherapy afterloader, a source, a iridium source or a cobalt source is kept inside this in a carousel. Okay. And there are some channels here which can be connected to an external catheter. So you can program it so it can come out at different channels. Okay, and those catheters up to 20-25 catheters, they can be put inside the body, either surgically, or if you are treating skin or superficial lesion like a palate, all kinds of things, you can put it in some the flexible material and then put it in near the surface, near the palate and all kinds of things. But most of the times, suppose you are treating the prostate, then you have to put some needles, some hollow needles, and through the hollow needles these catheters will go, and then you have the source strength is constant, but you know that where the source is going to step into. Okay, you can, from an image, you have a target already delineated, then you decide and you put the catheters, take an image, and then from there you know that what are the positions available for the source to step in, and those positions can be optimized. Either you go there or don't go there, and then how long the source is going to stay there. That is also something you have at your disposal. So then you optimize them. Then you know how much dose to give to the target. Then you go, there's a software available to do inverse planning, and from that inverse plan you do optimization, determine the dual positions and dual time, and then give it to the computer which controls the movement of the seeds, and then you irradiate them. Okay, so this is very much possible, but still then it's interventional. Okay. Okay, brachytherapy, we finished brachytherapy. Okay, not applicable to all sites. So this is called, there is something called intensity modulated radiation therapy. It is inverse planning based on dose volume constraints. What is dose volume constraints? Here. So the physicians give you a detailed prescription that how much dose you want to give where. Okay. So that's the prescription is given to the target here, and these are the critical organs. I am showing here you a example of treating a prostate cancer. So the beam can irradiate from any angles, but let's consider only 3 different angles that you are considering. This is a lateral angle, this is anterior to posterior, this is some kind of oblique anterior angle. So when you have this objective, what dose you want to give, and then of course every time optimization process you get how much dose you are getting from different angles, then you wanted to achieve this goal. This is the first iteration. You start with doing some guess and start with this one and see that what is the difference, and then optimize it. So eventually if you keep on iterative optimization, then eventually you will go as close as possible to this your desired level. Of course there are uncertainties that you have to take into account. That's a little bit more complicated. Let's not go into there right now. So then by doing this optimization, you get an intensity pattern. This is what is the intensity pattern. You get an intensity pattern here. These are the, so from this beam, you see you wanted to protect the bladder and rectum, so the intensity pattern looks like this. For this beam here, you wanted to protect the rectum, but you want to irradiate this part, so the intensity pattern will look like this. And for this, you want to protect the bladder, so that's why the intensity pattern will look like this. So you get from the inverse planning a theoretical intensity pattern, that what you want to use to achieve your goal. But how you are going to deliver that. So then eventually there are programs. Okay, this is the machine I am talking about. This is a external beam, true beam here. So in this beam, the electrons are accelerated and they hit a target, and the Bremsstrahlung X-rays come out here. So the depth dose will, in the beam direction, their dose distribution will look like this, and in the transverse direction, depending upon the field size, what is the irradiation area, the profiles will look like this. So what will happen is, this is called lateral penumbra. You wanted to spare the organs at risk. You wanted to put the target here. So target is getting the homogeneous dose here, the prescribed dose here, but critical organs are being spared by this lateral penumbra. Of course, there is a depth dose here, but because of X-rays, they exit out of body. Always there is exit dose. So there will be some dose to other organs, but by putting the beam from different directions, you try to minimize them. And specifically, if you have a rotational treatment, that is very much used nowadays. Nobody uses static single beam, static beams anymore, unless otherwise the target is very simple. But most of the treatments are now possible, something called a volumetric modulated arc therapy. Volumetric modulated arc therapy, that's called a VMAT. That's the most of the treatments are done there. In that case, this machine is rotating around and delivering a different intensity pattern at a different time, at different locations. So that's why it's called volumetric modulated. The treatment is given to a voxel, but that depending upon the beam direction, depending upon what critical organ is in the path of the beam, so that intensity pattern is modulated as the beam is rotating around. And when it is rotating around, see, I told you that you create by inverse planning a intensity pattern, and that intensity pattern has to be delivered. So inside that machine, there is something called a multi-leaf collimator. Very thin 5 millimeter, even 1.2 millimeter thick, wide, and thick enough to what is that called, to shield the radiation. To shield the radiation, 6 MB beam, nothing will come out of when the beam is hitting that collimator, nothing will come out, and they are very tightly packed. Okay, but they can move around. Those are one of the inventions that helped to do intensity modulated radiation therapy or VMAT. Without multi-beam collimator, we could never do it. Of course, then you can do some compensators and all kinds of things, but it's very complicated. But also there was some machine, you have a, that's called the tomotherapy. You have a binary collimator. It will open or close, open or close, open or close. So those openings, how much radiation you give through that openings can be also optimized. Okay, so to get the how to use how to get your the dose distribution that you like. Okay, let's move on. So these patterns are created and then you irradiate the patient. Then how we have moved in radiation therapy in external beam. In the beginning, when we didn't have image-based planning and inverse planning or IMRT, intensity modulated radiation therapy, or volumetric modulated arc therapy, the dose distribution looks like this. You irradiate a lot of normal tissue. So people used to have a lot of complications. Then we came with intensity modulatory proton therapy, spared a lot of things. Then we came rotational volumetric modulated arc therapy, then we spare much more, okay? So this is what is happening in nowadays. This is the latest development, and this is how a prostate looks like. And then we have also developed the ability how to treat a moving target, okay? When you have a moving target, what happens? This target is moving around, okay? So in order to irradiate this, what you have to do? You have to create an envelope of the target that's moving around and then irradiate that. But what is at what cost? The cost is that a lot of normal lung is being irradiated because you are trying to create an envelope of this moving target, so you irradiating the whole lung, so the lung gets a lot of dose and then people develop radiation pneumonitis and all kinds of things, okay? So that's what happens. So in order to avoid that, there are many techniques are available now. You can ask the patient to hold the breath and then irradiate it, because the patient is holding the breath, you are monitoring it, and during the breath hold phase you irradiate it. So the normal lung will be the dose will be reduced. So that's possible now. So and I told you about IMRT, BMAT, surface guided radiation therapy, and then this is breath hold treatment, and what else? Brachytherapy and nuclear medicine. Nuclear medicine is also very much used for metastatic patients, that and not for metastasis, for curative intent, for thyroid cancer, okay? For thyroid cancer, because thyroid is is a target where iodine goes and sticks to it, okay? That's why you are advised to, if you are living near a nuclear facility, you are always advised to take some salts with iodine, okay? So that will help you to survive any kind of irradiation exposure. So iodine therapy is very much works very well for thyroid. That's a liquid. They give the drink with iodine in it, okay, radioactive iodine in it, okay. And also sometimes the nuclear medicine is making a lot of strides right nowadays, because that helps to provide some systematic therapy or some kind of if the disease is spread out, you can treat them with radiation therapy, chemo, and then the standard external beam or brachytherapy. But you can ask the patient to get some nuclear medicine, and those radioactive compounds are tagged to a molecule which is tumor seeking. They will go and localize in the tumor, and there is a radioactive source, then it will irradiate it. So nuclear medicine is that's called radiopharmaceuticals, okay? That's also being used. Okay. This is how you do it, okay? Okay, this is the last thing I am going to talk about, and then we will stop, okay? About the introduction. So what are the steps involved in radiation therapy? First thing is the localization. The patient, of course, from diagnostic images, the physician, or from biopsy and all kinds of things, the physician has already, the radiation oncologist know already that what they want to do, where to irradiate, okay? But then we have to bring the patient to have a simulation in a position in which the patient is going to be treated. And in that time, we wanted to create or make the immobilization devices. Like if you want to take the blood, if you want to prostate cancer, then the patient has to be localized so that the pelvis is very much in a rigid position, so that it is not moving all around. Okay. So we want to treat the brain lesions. Then you bring the patient, create a mask, put a bite block, so that the patient is rigidly positioned. You cannot change. You know, in specifically when you are giving very high dose, that you wanted the mobilization to be very rigid, such that the movement will be within a millimeter. Okay. Sometimes they put a frame, sometimes a frame in the brain and the head, and screw it to the treatment machine. Those who do stereotactic radiosurgery, they might have seen this. Okay, I don't have a slide to show you, but that's what happened. The immobilization has to be very rigid, reproducible. If you do something that is going to change from day to day, then it's a disaster. Okay, so that is what happened. The patient comes first for a simulation session. They created that. Those things have been looked at and developed and standardized nowadays. But still some more work is being done, okay, to make it the localization to be as rigid as possible. And then patient comes localization. During the localization, a treatment planning, imaging are also taken, like the CT scan that is going to be used for planning. One thing I want to mention is for photons or for even protons, because the CT scans give you a electron density information, and electron density plays the major role in dose calculation. So the dose calculations are done in CT scans only. All other images are taken. They help the physician to draw those targets and all kinds of things. Nowadays we have a fusion software, so you can have an image from CT, you can image from MR, you can have a PET scan. All those things can be fused, and you have a great idea in the CT scan that where is what. But CT scan is the primary image where the treatment planning happens, the dose calculation happens. So that's why when the patient comes for a simulation, a treatment planning CT scan is taken. A treatment planning CT scan is taken, and in the treatment position, the local with all the immobilization devices and everything, the image is taken, and then it is sent to the treatment planning system, which is a computerized system. Nobody does hand treatment planning anymore. It was done long time ago when computers were not available. Okay, so when I started my career as a radiation physics in 1990, that's when the computerized treatment planning systems developed. Before that, it was pretty rudimentary. Okay, so let's don't go back again. Just like the people who live in using cell phones or smartphones, they cannot imagine how people were communicating long time ago when these things were not available. Okay, unimaginable. But that was the life that time. So and then after that the planning happens. After the planning, the plan is sent to a computer controlled electronic medical record, which is monitoring how the dose is delivered and recording it. Okay, so all those information are sent. Then there is a delivery happens, and during the delivery you have different imaging modalities. Like as I told you that nowadays you can take cone beam CT during the treat before the patient dose is delivered, and you make sure that the target that wherever the target is wherever you want it, and then you can create a orthogonal X-rays, and from the treatment planning we create something called a digitally reconstructed radiograph. From the planning CT you can have projections of the different angles. Like say I wanted to look at how the body's anatomy look in a orthogonal X-ray image. Like you took a X-ray from the anterior posterior direction and you take a film, and that film will be compared with the anterior posterior digitally reconstructed radiograph, and they will be matched. If they then sometimes because of the positioning from day to day vary, you have to apply some shifts and to make sure that those two, the reference image and the image for that day, are matching. Okay, so those shifts are determined, and the patient is ready for irradiation, and radiation is delivered. One of the things we would like to do is in our wish list that if you can verify what you are delivering in every time. That is one of the weakest points in the current practice of radiation oncology, because we do not have the tools to see what we are delivering there. But nowadays some development has taken place that when you are irradiating the body with some radiation, that electrons, they can emit something called Cherenkov radiation. So the Cherenkov radiation can be imaged by camera now. So when you are irradiating, you can see some kind of a glow in the patient's skin, and that can be calculated, and that glow is compared with the calculated glow, and then you have some idea that what we planned, what we delivered. Or another thing you can do is put a silicon detector on the exit path of the beam and calibrate that to a known dose and known pattern, and from there also you can reconstruct what dose you are giving. That's called electron portal imaging. Okay, that's possible. And for proton irradiation, when proton is delivered or a carbon ion beam is delivered, they interact with the tissue material and they activate them. There is some activation. There are some positron emitters, and those positron emitters those positrons will annihilate with an electron, and they can create a PET signal. So you can put a PET during the treatment machine and can scan it and to see that what you planned is what you delivered. Verification, but it has not been successful. But those are the wish list. The wish list, if you are an engineer or if you are planning to work on research and development, this is an area that radiation oncology is waiting some new innovation to happen. Okay, how to monitor the dose, and this is very important for proton and carbon and beams, as I will mention during the other lectures. Okay, so we have now image-based planning and delivery. Highly conformal radiation therapy is possible with all those beams. Okay, so that's how the radiation therapy has been developed to a very sophisticated, precise treatment modality. It's a good time to stop. Did you get enough idea about radiation oncology? And what the physicist does? Okay, the physicist role is treatment planning, but you have to know what dose you are delivering. So one of the major job of a physicist is to calibrate the beam, to verify the dose. So those are the things covered in the area called radiation dosimetry. And I believe Dr. Giri and Saurav, Anjan and Saurav, they have given you enough information what dosimetry is. It's difficult. I will talk about the proton dosimetry. Okay. Hopefully at that time, if there is something that you are not able to understand, I can explain you. Okay. But sometimes what happened after being practicing in the clinic, some of the things that you need to know about the dosimetry requires a substantial amount of time. I cannot probably cover it. Okay. So, okay, simulation, treatment, delivery, all kinds of things. And okay, let's talk about adaptive planning. I'll give a lecture on adaptive planning later on, adaptive proton therapy. So as I mentioned, the patient comes for a simulation, then a CT image is taken, and that image is used for planning. But what happens if change takes place? You are irradiating the patient, the target volume can change. If the patient is responding to the radiation, the tumor may shrink. And also some of the anatomy in the path of the beam, they can also change. So how do you monitor them? So that's why, because nowadays you are able to take 3D imaging in the treatment position using the treatment machine. So that's called cone beam CT. Those cone beam CTs are very much analyzed, and physicians look at it. They compare with the initial treatment planning CT or the initial cone beam CT taken in the first day, and if they see any change, then they think that okay, we need to evaluate it. Then the patient goes and have another diagnostic quality in the image CT scan that can be done in the simulator room, or nowadays in the treatment room there is something called a CT on rail. So you can do a CT on rail, because the cone beam CT is good, but it is not good for dose calculation, and the soft tissue contrast is pretty poor. Okay, the cone beam CT gives you some information, but the quality is bad. In order to get a good quality image, you have to take the patient to a regular CT scanner. So regular CT scanner, but they have to first see that okay, substantial change has taken place. It warrants that we need to have another CT scanner. You see, CT scans, you are exposing the patient. You do not want to expose the patient onto unnecessary radiation. Of course, they are cancer patients, but that doesn't mean that we will irradiate them as much dose as we need to. No. So that's a principle called radiation safety principle called ALARA, as low as possible. Okay, reasonable ALARA, achievable. Okay. So that's what happens. Then patient takes a CT scan is taken, new CT scan is taken. Then you run your old beam that you are using in that plan. That's called a verification plan. If the verification plan compares well with the original plan, nothing is done. If there is some change has happened that is not acceptable, then you create a new plan. That's called adaptive plan. Nowadays, it is possible to do adaptive plan on the fly. Okay, there are machines available. The image quality is very high, very good with the cone beam. That's called a Helician or Ethos. Those are the treatment machines that are available. So you can use them to do a online adaptive plan. The patient comes, you do the imaging, and you do the plan, and use the plan for that day. Use the patient to treat. So that has become very sophisticated. So every day you are making sure the dose is given to the target as prescribed, and we are sparing as much as the normalities as possible. Okay. And then of course, you keep on continually monitoring if you are not using one of those machines, and keep adapting. So the work, there is enough job for the physicists so that they will have a job, they have job security. Okay. That's all. All right. So what we have achieved so far by moving, so by reducing the dose to normal tissue and giving more dose to the target, we are able to maximize this therapeutic gain. We have tried to increase the TCP, and by moving this NTCP curve, because we are giving less and less dose to the normal tissue, we have increased this therapeutic gain. Okay. But what happened is, I'm moving gradually, taking it towards proton. Why we need proton? Okay. What time is now? I don't carry watch. Okay. So that's why I was late. What is it? 10:10. So in 5 minutes we'll stop. I'll take a break. Okay. All right. So these are the options, terms that I have already talked to you, most of them. Stereotactic ablated body therapy, sometimes it's called SBP, SBRT, IMPT, carbon ion therapy, all those things are for external release. We have very precise location and dose are possible with IGRT, image guided radiation therapy, and surface guided radiation therapy. In photon treatments are mostly focused on OAR sparing with lateral penumbra and spreading low doses to large volumes of normal tissue. That is how photon treatments are done. You remember I showed you a lateral profile and told you that in order to spare the normal tissue, you try to keep the OAR in the penumbral region as much as possible. But the photons have always an exit dose. Okay. So then comes the proton beam. Okay. Let's see if I have that. All right. Here is how we'll go into details what this is, but this is how the proton and carbon ion dose distribution looks like. Okay. This is the photon dose distribution. Always there is some exit dose. But protons and heavy charged particles, there is something called a Bragg peak, and after that dose falls up very fast, and that is called that's in the beam direction, and that we call it a longitudinal penumbra. So the protons or carbon ions or heavy charged particles have something new, something more than the lateral penumbra. That's called a longitudinal penumbra. So having a longitudinal penumbra in addition to lateral penumbra gives you some degrees of freedom, more degrees of freedom to spare the normal tissue, as shown here. You see, this is a proton treatment of the craniospinal axis, and this is a photon treatment. Because this exit dose, you get all these organs get some dose, but for protons nothing happens. Okay, this is how the proton machine vendors, they sell you to buy a proton machine. See, we can spare all of the things. But life is not that easy. Okay, life is not that, as you will see later in my lecture. So we'll stop here. Okay. So I gave you a tour of how the current treatment the current treatment flow with the X-ray machine, and I show gave you a very simple introduction of what protons can do. Okay. Now we'll go deep into protons next session. Okay. All right. Take a break. I'll also take a break. Okay. So see.